Very good morning, Himika ma'am, and a very happy World Sight Day to you.
Hi Megan, good morning. Hi Yogita, good morning. Hi Madhulata, good morning.
Hi, good morning.
Megan, can I say good evening or good night? Thanks for being there. Larry, you might want to unmute Megan.
There we go. Thank you so much, Amika. So good to see you. Yogita, so good to see you too. Yes, it's evening here.
Same here.
Evening
Good
here.
evening.
I'm glad you guys have a beautiful start to your day there. I hope it's a beautiful day.
I know.
Madhulata, good morning.
Hi, good morning.
Very good morning, good afternoon, good evening to everyone. I welcome you all for the webinar today. This is World Sight Day 2020, and we are offering a free webinar on eye cancer awareness in collaboration with Know the Glow USA. My name is Larry Wagh. I'm a nurse from Pune, and I teach at Bharati Vidyapeeth, deemed to be University College of Nursing, Pune. And my daughter, who is 2 years old, her name is Abigail Wagh. She is diagnosed with a very rare kind of an eye cancer, which is called as retinoblastoma. So it was around May, when we found out that she had a typical description or a typical presentation in her eye, in her left eye. And it was very difficult for us to understand what it was. We went and we showed her to the pediatrician, but the pediatrician said that it is common, it happens in children, it is nothing to worry, and we skipped the actual diagnosis. But sooner or later, we happened to go to the eye specialist, and at KKI Institute Pune, she was diagnosed uh, with the advanced stage of this tumor or cancer. It was very difficult for us to understand because at that time we were in lockdown phase in Pune city, and it was very difficult to take a decision on traveling, on getting the treatment. But by God's grace, everything fell in place, and we got the management health and requirement met by coming to Mumbai, and we started the treatment at Baijarbai Vadia Hospital and SRCC Hospital. Presently, Abigail is keeping well and she's still undergoing treatment. Looking at the need of awareness, I have taken up this national awareness campaign for retinoblastoma, and I have with me Dr. Himika Gupta, who is the ocular ophthalmologist, and is presently treating Abigail. And she is also helping us to share and spread awareness regarding the eye problems and eye cancers. Also, we have with us Dr. Yogita Rajgandhi ma'am. She is a very special or a very unique person in her field of optometry. And I welcome ma'am you for this webinar. We also have Dr. Madhulata Umesh ma'am, who is an optometrist and an ocularist, and she has her own specialty of working and preparing prosthesis of the eyes and rehabilitation. So I welcome ma'am as well. And we have a very special guest. We have Megan Weber from USA, Los Angeles. And we both share something like a similar story of finding out that our child is having a rare eye cancer or a rare eye disease, and what steps we have taken to ensure that not just our child but everybody else in the community receives the best care and treatment. So we're going to witness and listen to Megan Weber herself from USA, and she will be sharing out what she has done, how she has done this, and how we all can come together and we can learn and grow and help to reduce or detect eye cancers. I'm very happy to see all the students here, faculty, principals, respected dean, for attending this webinar. I'm really happy. It gives us it gives us a lot of motivation to do activities as such. And we really want to ensure that everybody in India get or abroad get to know about how to diagnose or detect early cancer. It is a very simple and easy method, and it will go a long way in helping identifying the diagnosis in children, and it will help in prevent blindness, and it will also help in saving lives. So with this, I would like to welcome each and every one of you for this auspicious day, that is World Sight Day, and we have kept this webinar especially for everyone. I know everybody is very keen and excited to listen to our presenters. So I will not hold back. We are going to begin with the first session. Himika ma'am, are you ready, ma'am?
Yeah.
Yes. So we before we begin, I just wanted to again highlight that if you have not filled the registration form, this is your last call. Please fill the registration form. It is in the chat link. The link is in the chat, so please fill it. I will be closing the registrations now. I thank Megan Weber and Know the Globe for providing us with these images, which are pretty much the main reason why we are having this webinar today. So I would like to introduce Dr. Himika Gupta. She will be telling about the importance of early detection and Bruckner's reflex, the red eye reflex. Dr. Himika Gupta has completed her MBBS from the prestigious Seth GS Medical College and KEM College Hospital, Mumbai. After completing her MS in ophthalmology from GMC Nagpur, ma'am has trained in ocular oncology at LV Prasad Eye Institute in Hyderabad. Ma'am has thereafter trained at the KBHB Eye and ENT Hospital, Mumbai, and has worked with the team at Tata Memorial Hospital, Mumbai. Dr. Himika ma'am further specialized in her interests by training in Canada at the Hospital for Sick Children, the University of Toronto, and the Princess Margaret Cancer Center in Toronto, Ontario, Canada. Her special area of interest is ocular oncology, retinoblastoma, socket, orbitofacial reconstruction, prosthetic rehabilitation. She is presently the director for Spectra Eye Clinic in Navi Mumbai. She is the ocular oncologist and oculoplasty specialist at Wadia Hospital, SRCC Hospital, Krishna Eye Center, and she is also the nationwide ophthalmology in charge for the NGO Doctors for You. So with this, I welcome ma'am, and I share the time to ma'am to take over the session. Thank you so much.
Thank you. Good morning and good evening to all who have come. I would like to sincerely thank the organizing team and all the dear audience on this World Sight Day to have us here, have this awareness program. So without delaying further, I would be talking on the red reflex or the Bruckner's reflex. I'm sure most of you must have heard or at least done the Bruckner's reflex. I would like to acknowledge my past affiliations and institutes. Some of the patient pictures are from here. And with that, let us look at what we'll try to go over in the next 25 minutes or so. We'd like to find out what is the Bruckner's reflex or the red reflex. We'd like to know how do we do this test correctly, what is the utility, and what is its role in retinoblastoma? Because as Larry said, that retinoblastoma is an eye cancer and we can pick it up early if we do the reflex properly. What is its impact in various scenarios? So today we have in our audience people from different backgrounds, different geographic locations as well. So what is its impact and how can we incorporate this in daily practices? Okay. So just 2 words about retinoblastoma. It is the most common primary intraocular tumor in India. So it is the most common eye cancer in our part of the world. And all over, it's a rare cancer because generally we have 5,000 cases, new cases per year all over the globe. Out of these, 1,500 are from India. So we have around 1,500 new cases estimated to occur every year in India. Most of the cases occur in children less than 3 years of age. This is an under 5 malignancy. So a baby who is still a toddler or just joined nursery or preschool is not going to tell you, I can't see from one eye. So that becomes a challenge. So it mostly occurs in children below 3 years and the mean age is 18 months, which is 1.5 years. 1/3 of the cases could be bilateral and they could have a genetic cause, which means that it might run in the families as well. How does it present? The commonest presentation of retinoblastoma in India still is leukocoria, or the white eye reflex. We are going to talk a lot about leukocoria. Your registration form also talked a lot about it. Basically, we have taken up the task to ensure that we drill leukocoria into your brain today by the end of the webinar. Also, squint. So what we need to remember is that squint, or the eyes looking inwards or outwards, should never, ever, ever be ignored. If you remember this point and disconnect the Zoom meeting right now, I wouldn't mind it. But please remember never, ever, ever to ignore a squint, because that could also be harboring a tumor in the eye. Retinoblastoma is a tumor which grows inside the retina and then comes out and has a tendency to spread here and there, sometimes to the brain, sometimes to other parts near the eye. It can sometimes present as a masquerade, which could be a hypopion or a pus-filled anterior chamber or a painful red eye. Or the mom says that, yeah, the eye went red, nothing was wrong, he didn't really get hurt, but the eye is looking red and painful. So that's one place where you would want to be suspicious. Now, why do we want to pick it up early? I mean, why so much of a hue and cry over the red reflex? Why are we having an entire webinar for the red reflex or the leukocoria, red versus white? Why? Because if we pick up the tumor early, then the tumor is still very small. There won't be any need for eye removal. There are ways to control this tumor, this cancer of the eye, using lasers and chemotherapy to shrink the tumor. And there are less chances of tumor spread. We can sometimes even preserve the vision. And there'll be lesser invasive procedures. Nobody wants to have their child go to the hospital recurrently, get some surgery, get repeated chemotherapies. If we can do a minimum invasion and then tackle the disease, everybody would prefer that, whether an adult or a child. And of course, the cost of medical care. Because if you detect the tumor later, the kind of procedures you need to done and the chances of saving the eye or the site keeps decreasing and the procedures keep increasing. So science and evidence has already proved that early detection of retinoblastoma is associated with much superior outcomes. With this, I hope I've sort of told you or explained that why the red reflex detection or knowing about it is important from retinoblastoma point of view. So what is this red reflex? Many of you might have already read about it. It is also known as the Bruckner's reflex, and it is a normal phenomena wherein the back of the retina reflects light to any light that is flashed on the eye, and it manifests as a red spot. Often in our photographs of social gatherings, which would happen in pre-COVID era, of course, we would have, we would look at our photos and we would go, oh shoot, there are two red eyes, I have a ghost like red eyes. So, well, it's a good thing to have those because it is safe. It means that your eyes are pretty much normal. We also have applications which can do red eye removal, right? We have on our cell phones and cameras, red eye removal apps. So the red eye, both eyes appearing red during flash photography is a very normal phenomena. And that's exactly what we need to ensure is happening in all kids. Now, how often are we supposed to look at the red eye? Well, according to the American Academy of Pediatric Ophthalmologists, the red reflex examination should occur once at least between newborn and 12 months, that is within the first year of life. If the red reflex is abnormal, then the patient has to be referred to an ophthalmologist, meaning the red reflex doesn't have to be done by the eye doctor. It either has to be the healthcare worker or the immunization nurse or the pediatrician or the pediatrician's assistant or the optometrist, not necessarily the eye doctor. If it is abnormal, then the eye doctor has to dilate and look into the eyes. Same story between 1 year and 3 years. Again, at least one red reflex test is mandatory. Between 3 to 5 years, once more. And 5 years and older, we recommend an annual checkup. So what's the scenario in our country, India? I'm saying our because most of the audience I'm assuming are from India. The government of India advocates preliminary screening and examination by the ophthalmic assistants and dispensing of specs for children above 6 years. So it's generally a 5 to 15 years of age program. Okay. What happens to the preschoolers? Well, it has been found that in the current scenario, they are difficult to locate. We all know that the preschool lasts for 1 or 2 hours, and they either come in or they don't, or they keep crying, or they don't want to really come in. The kids are not readily available in school. They are uncooperative for vision testing. Of course, if you make a 2-year-old or a 1-year-old sit and try to read out, they really can't read. So that doesn't make sense. So there are logistic problems and financial burdens. Therefore, currently, the government does not advocate preschool eye screening. So all the pre-verbal and preschool kids in India do not have a mandatory eye screening program. However, we have the largest child population in the planet. 30% of our entire population is children. We are a young country. And out of that, 10% are 0 to 4 years of age. So we are not providing any kind of vision screening services to them. Not all kids reach school. They might have developmental delay, severe problems, severe vision problems, and they are assumed to be not so good and they are not enrolled in school. There are special children, financial and logistic problems. So starting eye screening at 6 years of age, you've already missed the bus. There's something that needs to be done to the under 5s. And that's where the role of various simple screening tools comes into play. It's a good idea. Why red reflex? Of course, red reflex is important because we want to catch them early. We want to catch the children who don't land up going to a formal school. We want to simultaneously sensitize the parents and do a sibling screening if possible and pick up potentially life-threatening diseases. One being retinoblastoma, the other being squints, because some brain tumors can manifest as a squint in the eye. So there are various ways in which a red reflex can be tested. The commonest and most inexpensive is the Bruckner's test using the direct ophthalmoscope. We also have photo screening devices and the photo red test, which involves using of a flashlight camera. Today, I'll be focusing more on the Bruckner's test, and let us now go through on how we are able to do the test. Larry, I would want you at the end of these steps, there'll be some question slides, So I would want you to have to monitor the chat box and people can type in their answers, okay?
Yes, ma'am.
So that will be more for the students. So I have this habit of grilling the students whenever I get a chance. So I'm taking that chance today. Okay, so steps. Step 1, it should be a dimly lit or a dark room and the child should be sitting on the parent's lap. You might want to draw the curtain. So just make it a bit dark. Don't do this near the curtain, near the windows. Okay. So when we go out in the community, we do a lot of screening for the Anganwadi kids. That is the system in India, in rural India especially. So we ensure that the Bruckner's is done in a dark corner of the room, not like in next to the window without curtains. Second, use a direct ophthalmoscope. I'm sure most of you know how a direct ophthalmoscope looks. It is a mandatory thing and really it is a worthwhile investment. It's a good idea to have one of your own and put the lens power at 0 and make sure that the batteries are well charged. Then shine it like a torch on the patient's forehead. Now there are many techniques. I'm sticking to ½ meter and 1 meter. These are 2 ways. So remember, this is a no touch technique. You don't have to hold the child. The child comfortably sits in the parent's lap and you simply shine the torchlight or the light of the Bruckner's on the patient's forehead and try to look at both the eyes or the red reflex shining from both the eyes. This is another image from that. There is a very nice, I have not cut out cropped this. This is a red reflex detection video. Please, I would encourage, no financial interest, but I would encourage that all of you might want to see this video. If it's a baby, the baby keeps sleeping and they are in a sleeping position, you might want to hold them like this in a aeroplane position so that they really open their eyes for a bit and you can check the Bruckner's reflex in them. Encourage the child to look at the light and direct the light at the child's eye individually first and then together. An equal and bright red reflex from each pupil should be seen by the physician. Carefully note the color and brightness. That is where our experience comes. So what I always tell my students is, right from day one of your optometry, especially, or your ophthalmology course, start doing Bruckner's reflex on each other. You should know the correct color to pick up the abnormal color, or you should know how the normal looks. Okay. So this is a resource which is freely available on the internet. So the first image is the correct reflex. The normal red reflex looks like an orange to red glow, and it should be symmetrical. So both the pupils should have the symmetrical glow. If one eye doesn't have a same looking glow, then it spells problems. So in photograph number 2, the reflex is absent. In photograph number 3A, the reflex looks more of white. Okay, the one on the left with the green tick, it's already, so the one with green tick over here, this one is a normal reflex. The pupil size may vary because if you put dilating drops, the pupils might be bigger, and I will come back to that. On the abnormal side, as you can see, this most probably could be a cataract. Now, why does the reflex look abnormal? There are many reasons for that. We said that this is generally occurring due to the reflection from the retina. So if there's a problem in retina, like we say retinoblastoma or even retinal detachments, the reflex will look abnormal. If there's a problem in the media, the reflection comes through the cornea and the lens and the vitreous, which are the transparent parts of the eye. So now if these transparent parts fail to be transparent, suppose there's a cataract, suppose there is a scar, suppose there's an opacity, then again the reflex will not look same. The third thing is the refractive errors, because of which again the way the light rays bend, the shade of the reflex may not look the same. And the fourth common cause is if we have a squint where the eyes are either looking inwards or outwards, then when we flash the light and the child looks straight into the eyes, you might not get both eyes reflex having the same shade because one of the eyes is aligned differently. Is this clear so far? I'm taking that to be a yes, and I'll continue. So in the last picture, as you can see over here, it is more of a yellowish white reflex, and this is what we call the leukocoria. So when the red reflex shows an abnormality and it starts looking whitish in color, leuco means white and coria means pupils. So the pupils look white in color, and that is what is leukocoria, and that's something we don't want to miss. Okay. So this is the interpretation. If both the pupils look round, symmetrical, and the orangish glow is present, it's a normal result, and we want to just screen this child, say every 1 year or as per the protocol. Now, if there is any asymmetry in both eyes, a pupil could be big or small, the color intensity, shape could be different, the shade could be different, or the reflex might be absent, or it might be a black reflex. There can be a lot of things. That simply means this is abnormal. You must remember to refer these patients for a detailed eye examination, and they really warrant a detailed retina check also after putting drops in the eyes. In case the child is asleep, in case we see a Bruckner's or red reflex and we are like, well, I'm not sure, maybe it's normal, maybe it's abnormal, and this is what happens many a times. Then what do? Then we can label it as suspicious, and then we can either repeat the reflex on another day just to be sure, or we can put some dilating drops, and then again once the pupils become slightly big, repeat the Bruckner's testing. Okay, with these things we are reasonably able to achieve our goal of screening. So now we are coming to the quiz part before I end. So here, which side you feel is abnormal? Anybody can chat, can type in the chat box perhaps. Nobody?
We have received an answer right and
Left, yeah.
left. Majority are saying left. One has said right.
Very good. Farina is very good. Yeah, that's the first answer that came. Very good. So the left eye, and it looks, there's some blackish thing. So mostly it's a media opacity. So we want to look at whether the cornea is clear, whether the lens has a cataract, whether vitreous has an issue. Very good. Okay, we'll go to the next one. This one, what's the problem and where is it? Give me your differentials. Yeah, good. I think I'm getting some lefts. Yeah, so you can clearly see that the eye is inturned. This is a case of squint. Okay, sometimes subtle squints, you won't be able to pick up maybe on a torchlight, or the child is not cooperative. See, nobody likes to go to a hospital or a clinic, right? So they're not really in a good mood often. So it's a good idea to do this test from a distance, not touch them, let them sit comfortably in their parents' laps, and quickly just have a quick check. It gives a lot of information. Trust me, it really gives too much information. Yes, yeah, Purvi Saxena is total, a lot of people. Parinaz, yeah, very nice. We are getting a lot of answers, yeah. Okay, now this one, what do you feel? Yes. Yeah, Purvi is like, she's getting fastest fingers prize. We might have to give that to her. It's both the eyes, correct? Because, yeah, that's not red. So we would want to evaluate both eyes and see what's going wrong inside their eyes. Yeah. And this one? Okay, good. Yeah, here we are not sure it's the right eye or the left eye. Yeah, but I would say it is the right eye, correct? Because the reflex looks asymmetric. So this could be a very high refractive error, or maybe something wrong in the retina. We need to check. Mostly astigmatism. Good. Yes. Uma, thank you so much. Yes, that could be the correct answer. So we get a lot of differentials just by this 1 second test. This one? Yes, this is normal. So when we start looking for abnormal, we should not forget how a normal eye looks. That's why we should start doing Bruckner's on each other. If you're not confident, just do it. It's okay. Yeah. Okay. We keep clicking images of each other. We might as well try the test with the ophthalmoscope and improve our own skills. So just 2 lines about the photo red technique. Here we encourage the parents to take different angle photographs with the flash of the camera or the cell phone on. And when you take multiple photographs, you just want to check whether the red reflex is coming and whether it's symmetrical or not. There are a lot of specifications regarding to distance and room lighting, but more or less, it's a good idea to just encourage patients. In Canada, I know Brenda calls it the grandmom's test. So you just ask the granny to keep clicking photos of the child. Often, many cases of leukocoria and asymmetric reflexes get diagnosed during birthdays. So the first birthday is the one which generally draws attention. So that's one thing. We might want to encourage them to do a lot of flash photography and pick up abnormalities. Okay, so you use camera with auto flash, ensure that the light source such as table lamp is behind, not in front, so that the child doesn't squeeze the eye or you get an abnormal whitish reflex. Okay, and check that the camera's red reduction settings are turned off. Okay, so there's a inbuilt, so many of the phones and cameras have an inbuilt system, or you can have a different setting of reducing the red eye reduction. And try to be 4 meters from the child, but even at 1 meter you can really take the photos. Take series of photographs, keep checking, talk to you need not rush to the doctor. Sometimes this technique is not very reliable, so no need of getting very concerned. But yeah, of course, you must always bring that up in your next usual visit with the doctor. And like I think Megan and their team would tell us, that this red reflex doesn't just pick up retinoblastoma, it can pick up 9 to 17 different abnormalities. In fact, leukocoria itself has many differential diagnoses. So we can pick up corneal opacities, pediatric cataracts, very important, because if you don't treat the cataract on time, you might lose the vision to amblyopia. Hypermetropia, extremes of refractive errors, squint. Apart from that, retinal issues like Coats disease, toxocara, retinal detachments, so on and so forth. So there are a lot of things apart from retinoblastoma which can be picked up with this red reflex. So how do we do it? Now we know most of us in India, well, our government doesn't ask us to do this. So do we really have to do it? And how do we do it? Well, we did a lot of this along with the NGO that I work with. We also had a chance to use the Plus Optics device, which is a auto refractor screening tool. Apart from that, we did Bruckner's screening, and we did it in combination in 5 different setups. What we learned from this was that, okay, I need to see the end of this. Yeah. So when we did a urban population thing, like we were able to screen, generally it takes 1 minute per child, you know, they're not really so uncooperative. They just have to sit in their parents' lap and you have to sort of bend and do the reflex in a semi-dark room from 1 meter away. So it's not so bad. So our average screening time was roughly give or take 1 minute. Now that's not so bad. The other thing that we learned was that when we did opportunistic screening, that is when these kids came to the immunization OPD in the rural area of Khopoli, which is like, say, 60 kilometers from Mumbai, we realized that most of them came back to us. So during the immunization, it's the parent who's with the child. During the preschool, the parents may or may not be there, they are teachers. So in the preschool, you'll get more kids to screen. So in 170 minutes, you screen 154 kids. That's the upside. But in the immunization OPD, you'll get less kids. You know, you might not get such a huge number because it's not a class or a school, but you'll land up getting a better response. The yield is higher. So if you tell them that, look, this child has an issue, please come back for a full eye checkup, the chances are they'll do that more. They also bring in their siblings and you get a chance to have a one-on-one, patient or parent education. So that's very important. So again, opportunistic screening, which we also did at the SRCC hospital in the immunization setup, had a higher percentage of, detecting problems and also they coming back to us. Okay. So that is one thing that we learned a lot from this intervention that we carried out, more than 3 years ago now, 4 in fact. So I would like to conclude on these 2 notes. One is that red reflex is a simple and effective vision screening test, and early detection of eye problems in pre-verbal children is important. Life-threatening conditions like retinoblastoma, brain tumor-induced squint can be picked up, and so we must all learn to do it and practice it in our daily practice. Vision-threatening conditions like amblyopia, cataract can also be picked up, and opportunistic screening model, that is going out to the immunization program and doing the red reflex test, really is more feasible. So so Uma will take your comments later. Thank you so much. So the road ahead is we must collaborate like doctors, nurses, optometrists. It's our duty. And we must introduce the red reflex or the Bruckner's test in Well Baby Clinic. It's a good idea to train ophthalmic assistants, health assistants to screen for Bruckner's. It's not in a busy practice, a pediatrician or an ophthalmologist or an optometrist or a nurse who's really sitting and giving those shots for immunization. I mean, we know our population. It's tough. So we can have the health assistants which are being trained. Like in our NGO, our social workers, everybody was very well trained to do the Bruckner's test. So we encourage a lot of training of our assistant level healthcare workers and the Anganwadi workers if possible to do this test. And inability to talk or read does not mean that the child can't have a eye exam. So whenever we go out in the community, if somebody comes saying that, look, so and so's child has a issue but he really can't read, so how do we bring him from an eye test, or he's too small to come back for an eye test, well, that's a wrong concept. It is very easy, and there are techniques to screen even newborns. So too small for vision evaluation really is a wrong term. We must learn to look into the eye problems of very tiny children, especially in the 0 to 5 years age group. With that, I would like to thank you. I think I have overshot the time. Sorry about that. Also, for those in Mumbai, we've recently launched this app called Hospitals for You, HFY. So you might want to check it out on the Google Store or the App Store. It is a hospital finding app, which is helping out people reach out to their healthcare needs in the current pandemic situation. So that's one more. I would take this opportunity to invite all of you to check out and download this app. It's live now. It was inaugurated on 2nd of October. And thank you. And maybe we'll be taking questions towards the end, or I would type it in the chat box. Thanks.
Thank you, ma'am. If you could end the screen share, ma'am. Yes, thank you so much, ma'am. That was a very wonderful expression of the entire concept of importance of early detection. And it is so important that we need to take these steps. As students, it is the best platform for you to try and learn in the college hours or in the practical hours in the community, so that when you are ready to be in the professional field, you are ready to identify these cases and you're ready to refer these cases. So I would like to thank ma'am for giving this wonderful message and information related to diagnosis of different kinds of conditions apart from retinoblastoma. And I think with practice and with regular understanding, it will be really easy for everyone. With this, I would like to quickly move on to the next presenter. I would just like to share that if you have any questions, can you please share it with everyone, just not the presenter. It will be really easy.
Everyone, not in private chat.
Yes.
It becomes very hard.
So it will be really easy for us to get back to your question, and we are ready to take all the questions. So you can just put it in the chat and we'll try to resolve your questions as soon as possible. Moving on, we have with us a very special person today. I would like to just introduce who would be taking on low vision management, that is care of sight and vision. We have Dr. Yogita L. Rajgandhi. She's the consulting optometrist, and the bedside besides optometry, she also has pursued her MD in alternative medicine from Sri Lanka. She is also trained in Indian Sign Language from NIHH Mumbai, a diploma in philosophy of Jainism from University of Mumbai, and yoga and meditation from Mumbai. Ma'am is a faculty and external examiner at various colleges and universities in India. She was an ASCO India national representative and also an ex-head of the Low Vision Center, NAB workshop for the blind in Mumbai. She has been on the optometry faculties of the colleges which are mainly affiliated with YCMOU University. After a period of private practice, she has taken up academic graduation and fellowship from India. She was selected for the Master Teacher Training course in Disabled category from Ministry of Social Welfare and Justice, Lakshmibai Physical Education University, associated with Special Olympics Bharat, represented All India Sports Council for Deaf. She has also pursued professional photography course from British Institute, Mumbai. Dr. Yogita Rajgandhi ma'am has published more than 35 articles, reports widely in journals and publications in optometry, visual science and low vision, community and optometry and contact lenses. Ma'am has a vast experience in teaching subjects like low vision rehabilitation, sports vision, contact lenses, and community optometry, and has presented scientific papers and posters in many national and international conferences, and has participated as faculty in many national and international practitioner education programs in contact lenses, low vision, and clinical optometry. Dr. Yogita Rajgandhi ma'am presently is the only optometrist in India who learned the Indian sign language, especially to treat patients with hearing impairment. Today, she is associated with several NGOs, clinics, colleges, and various organizations. At this time, I would like to hand over the time to Yogita ma'am and take over. Thank you.
Yeah, thank you so much, Mr. Larry Wagh, and good morning and good evening to everybody. Thank you for an opportunity, and it's a wonderful day to start with educating the people and making lots of awareness about the visual impairment. And of course, the retinoblastoma is one of the causes of visual impairment. I would like to start with the statistics. What happens exactly? Every 5 seconds, a person goes blind in the world, and every minute, one child goes blind in the world. So this is a very scary thing to learn, you know. And we have the association called Vision 2020. Uh, that's basically aimed for elimination of the avoidable or needless blindness across the country and across the globe. Every chapter has a different geographical location. So what is the concept of prevention of blindness? How do we control? So one is the primary prevention, then you have secondary and tertiary level. So primary, you need to stop the disease occurring, which previous presenter, Dr. Hinika Gupta, has covered wonderful way to highlight how do you examine and comprehensive eye examination to come out of the retinoblastoma detection. But for the secondary prevention, you stop the vision loss from the established disease. So disease, once it is established, how do you prevent further? The vision cannot be lost further. And the tertiary level, it can only be restoration of the vision. So there are certain optical and non-optical devices which can enhance your residual vision, and that the person can able to live the independent life with whatever the conventional treatment is not available for them. So tertiary level restoring the vision, and the final comes when you have the education about the particular disease or particular visual impairment causes, the training you give it to them, and the rehabilitation. So rehabilitation plays very important role. As per the UNICEF, the childhood definition comes below the age of 16 years. And you can say the 40% of the children of all the population, where the 60% are adults, especially in India. So what happens here is the people who are developing from the different parts of the world, so developed and undeveloped country, I mean developing countries, there are 5 to 10 times more likely to go blind. In the industrial area, like in Australia, they have a less of ratio as per the visual impairment statistics as per the Australian government. So blind people are amongst the purest of the world poor because the poverty and the blindness goes hand to hand. I would like to share here some of the magnitude of disability. We have different kind of a disability. So there are 90 million people with a disability in India. Out of that, approximately 11.5 or 12 million are blind. And you have 200 million people are school age relative. As the previous speaker said, between the age of 5 to 14 years, we have a children going to the school and 20 million requiring a spectacle need for their education and to day their lifestyle. So that is why the government has come with a Sarva Shikshan Abhiyan, and that works from between 5 years to 14 years. 580 million people over the age of 60 years of the worldwide, which are 355 million people live in developing countries. So there are 12 million people who are speech and hearing impaired. 6 million people are orthopedically challenged. 24 million are intellectual disabled people, and 7.5 million people are mentally ill people. The number of blind people, why it is increasing each day, there are many reasons for that, but we have found out there are three major factors for that. So one is increase in our population, second is increase in the life expectancy, and inadequate eye care services, which even ophthalmologists, optometrists can reverse this particular scenario. Recently, the paper was published in 2 years ago in Lancet, which estimate there are 36 million people are blind, and further to that, 270 million people live with a severe or moderate visual impairment. And in total, so there are 253 million people are living with a visual impairment in 2015. And it estimates that 1.1 billion people can have the near visual impairment. Now we need to understand here, most of the time we consider the distance visual acuity, but there are adult population above the age of 38 probably have the near visual impairment as well, and they do not have the sometimes the accessibility or the awareness or the affordability. And that's why they do not do any kind of a near activity and they become visually impaired. So this can be avoidable, this can be preventable. As per that, I have already covered, there are key findings, like 36 million people are blind, so I won't repeat it again. What is the main importance of the low vision goal or low vision rehabilitation? Basically, it is to rehabilitate to help the each person who remains independent as well as to provide the ongoing support to them. Each case is unique, each child is unique, and there is no thumb rule for low vision rehabilitation. So we need to understand from the economy or social or their cultural or their education, the family support. On that basis, you need to do the proper rehabilitation. It can be done by recommending or dispensing visual devices or referring to community sources or providing support service to the patient as well to the family members as well. I just would like to share the definition of low vision, which is worldwide accepted, which is the person with a low vision who has impairment of visual function. We need to emphasize here the visual function. That means the functional vision ability which works in a different category, like the distance vision or the near vision or contrast sensitivity or the color vision as well. So even after whatever the conventional treatment, like a medicine or surgery, contact lenses or the conventional spectacles are being given, in spite of that, the person is not able to improve the vision, you can say by 618 to the light perception, but has some part of vision, which is called residual vision, can improve the vision to the particular low vision optical devices, and he or she is a potential candidate to function. His functional vision can be used in his day-to-day lifestyle. So probably what I could say is here, the person will not able to say the completely are blind. He has some vision which can be used for the particular task. I hope I'm clear with everyone, all the students especially who are listening. And the blindness definition is in the, according to WHO, which is the best corrected visual acuity of less than 3 by 60 in the better eye, or you have the peripheral vision, which is less than 10 degrees from the central point of fixation. So blindness and the visual impairment of our vision, they both are categorized by the WHO. And there are certain classification of blindness, like you start from the normal, in which category the normal person comes, which is from 6 by 6, which is the general denomination or the general way of describing when you go to eye care clinic or any hospitals, they will say 6 by 18, 6 by 12 or 6 by 6. And when you say it is 6 by 6, it is a normal. So 6 by 6 to 6 by 18, it can be a normal category. Then you have visual impairment, severe visual impairment, blind, and total blind, where there is no perception, there is no light, or there is no any finger counting. So that person comes into the category of the blindness, and they can be registered with the civil or district hospital. They are eligible for the blindness certificate as well. There are the different types of legal blindness, which is, as I said, vision less than 3 by 60, which termed as a legal blindness, and 6 by 60, which is termed as an economical blindness. And there can be avoidable blindness, which can be preventable or treatable or curable as well. If you come with the right time, right detection, and the right person, I'm sure we can save a lot of vision for the different children or the adults, you know. And recently, this is the NPCD has come with a different kind of a modification itself in the definition, which says that the initial nomenclature did not have the visual impairment. So now they have added the definition of the terminology of the visual impairment also. So I would say here how the steps follow. Once you have the disease, example, I have given here macular degeneration, which is the posterior segment disorders in a retina. When you detect the macular degeneration, what happens? So you decrease the vision, which leads to impairment. When you are not having the enough or adequate vision to function in your day-to-day life, whether you cannot read, you cannot see, you cannot travel, it leads to disability. And then finally, when you have the disorder, you have impairment, you have disability, which leads to a handicap, where you are not able to educate, you are not able to employ, you are not able to become a self-independent person. There are few different causes of blindness, which can be initially in the worldwide as cataract. The cataract is a major causes of blindness in the world, especially in India as well. Second is an uncorrected refractive error, which leads to visual impairment. And then there are many other causes of visual impairment, which is anterior segment or posterior segment disorders, like the diabetic retinopathy, glaucoma, age-related macular degeneration, corneal opacity. There could be some genetic eye disease and vitamin A deficiency, the corneal retinoblastoma, Thesis bulbi. There could be any albinism, retinal pigmentosa, amblyopia, microphthalmos, and optic atrophy as well. Now the common question comes, how do you know you have a low vision? That's a very common question comes with people around, and they do ask, how do I know? So I would say that here, with the regular spectacles, you are not able to recognize the faces or the friends of or the relatives. Even the near task is a problem for you. Like you cannot read with the existing glasses. You cannot do the cooking, especially by the females. And the difficult to match the color of your clothes in a daily, day-to-day life. At home or at your work, even the light you have, and even with the spectacles, you are not able to see clearly. So that reduces your contrast sensitivity and difficulty in reading the street or the bus sign. So you're not able to identify during your traveling the road name or the stop name or the bus number or the indicator as well. So first step here comes is identifying the low vision patient. Then you have to correlate with the visual loss, the significance of low vision and counseling, acceptance by the family, and the rehabilitation. There are certain examination methods you have to follow that and interpretation. I would say again emphasize on the residual vision to make the patient independent, which can lead to the productive way of life, definitely a disability, and you can change the quality of life with a certain low vision optical devices. We do the clinical evaluation in three steps, as I said, clinical, functional, and vision rehabilitation, which all vary from condition, symptoms, and the management as well. So I would say here, there are certain lifestyle implications. You can see the different pictures, and probably you can correlate with each picture, like a sports injury, the ocular, the reading task, your spectacles, your life, your family history, the personal history like smoking and alcohol, and then you have the travel history, communication, and the senior citizen life as well. So there are different kind of a lifestyle we all need to. Functional vision impairment, which refers to a significant reduction of the visual capability resulting from some pathological condition, which cannot be corrected with the conventional mode of treatment. And as I said, the functional vision assessment we see generally with a distance near visual field, color vision, and lighting, which is a contrast sensitivity. I would just like to say and share some optical devices. I'm sure most of the participants here must have seen or come across, or maybe in the family nearby, somebody must be using such kind of a magnifier. So those are like spectacle bifocals, magnifying lenses. There are hand and stem magnifier, the telescope. You have CCTV and the computer with a large font. So there are some pocket magnifier, hand magnifier, spectacle magnifier as well. You do have the electronic magnifier as well. So CCTV and different kind of electronic magnification can be enhanced with a computer or laptop or even with a television also. These are the very simple non-optical devices, but these are the wonderful way to do the day-to-day activities. So different guides are there, and the reading lamp, which can enhance some kind of a lighting or illumination to the patients who have more of reading problems. The reading guide specific for making reading a particular word in particular one sentence, so you don't mismatch or something, you don't miss out. Then reading stand for the stability, the writing guide, especially for the student who can write in one line. Then the signature guide, especially for signing the important documents. You have board line paper, students who write in a particular, the notebook. You have the felt tip pen, especially we give the black pen, which enhance with a white and black background. You have pencils, notex. Notex is a different name as of currency identification. Before 5 years ago, we have been following the same kind of a currency identification. But now since government has changed the different size and the color of the different notes of a 10 to 20, 50, and 500 and 1000. So, I mean, 2000. Definitely, we also have 10, the modified currency identification, and the needle threader. These are the absorptive lenses, which the people, especially having albinism, those have the extra, they are not very exposed to UV radiations, and they have the problem with the glare or the light. So people can able to wear these absorptive lenses. Of course, when you have the visual impairment or the low vision, there are lots of psychosocial effects due to the vision loss. It's very difficult to accept for any human being. And now he or she is not able to see properly like other peers, you know. So what happens? There is a discouragement, there is a frustration, there is a anger, distress, depression can be one of the reasons, fear and lack of confidence. But I'm sure we all can come out of that with a special motivation and counseling things. So I personally feel that various approaches are there in low vision rehabilitation, which works in a multidisciplinary approach, interdisciplinary, and the transdisciplinary approach. And if there are no specific rules, which approach is better? As I said again, there are, each case is different, each child is different. So according to that, we need to decide whether really this particular approach will be better for what and for whom. So there are common problems with any disability: the lack of functional independence, behavior problems, impaired intellectual skills, or communication problems. And we all need to take care of this. I would just like to enhance here the management part. First, you the assessment, that is a clinical assessment, then low vision assessment. You give the training of the low vision and optical, non-optical devices or electronic devices, because those devices are not like a special, the conventional devices, which you just in optician, you go and tell them, okay, you can start wearing this. But there are lots of training required, how to hold, what distance, what kind of a magnification required, what kind of a lighting required. So according to that, you give the training, and that's called visual rehabilitation. Then definitely there is the role of spatial educator, occupational therapist, orientation and mobility instructor who gives you the training, especially in a mobility, like you walk with a white cane, especially sometimes with a torch, and there is a smart cane available now. And in fact, we celebrate every year worldwide White Cane Day, which comes on 15th of October. Then there is a rehabilitation counselor, physiotherapist, and psychologist who definitely give you the boosting your confidence, motivation. Social worker plays very important role because they are associated with many NGOs and they come out with a financial or any assessment challenges you face. The speech therapists are there, and of course, every case the follow-up is very important part. So without follow-up, probably you will not able to do the justice to that particular case. I personally feel these are miracle devices. In my life and practicing past 10 years, I have found this devices, even the small or bigger or is expensive or inexpensive, but they do amazing work. And at the end, I make them very satisfied and they all are independent and working. So never stop believing in hope, as miracle happens every day. And I hope there is a take-home message by this presentation. I personally feel the success in life depends upon two things: the vision of seeing the invisible things and mission of doing the impossible things. And that is why I think so we all are connected today, associated with each other, because we all want to make a difference to the lives of different people. And she's one of my patients who says she's not lucky, but she's blessed because she got and she received the right time, the low vision rehabilitation management. So I just want to acknowledge Mr. Larry Wagh, the Abigail Wagh, Know the Glow, the US Foundation, the National Association for the Blind, because I have used some of the pictures. MNB Industrial Home for the Blind, who are some of the visually participants are there. And definitely Indian Farmers, Maharashtra Police and Indian Army. Without that, we all not be sitting safely at home. So, and my parents and family. I would like to place I would like to place organ, and I would like to recommend everybody, please come forward, extend your support and donate your eyes, because that's the only thing, beautiful gift you can give it to somebody. You can get connect with me by website or Instagram, Twitter, cell or email. Thank you so much for listening, and thank you so much for giving me this opportunity. And I hope we all can do justice. And that's the way I would like to end my presentation here. Thank you so much.
Thank you so much, ma'am. That was very insightful. Yes, ma'am. That was very insightful and very, very important. I think you covered so many things in such a short span of time, which is commendable. And I hope that many of the students and attendees here have gained a lot of information from you. We are trying our best to make sure that we provide the best for you today. Thank you so much, ma'am. It really means a lot that you could put up so much information in such a short span of time. And we would like to let you know that it is a very good privilege for us to have you with us for this meeting. To move ahead, because we're short of time, we will be going into our next presentation. Okay. So our next presenter is Dr. Ms. Madhulata Umesh. She will be talking about ocular prosthesis, the different types, indications, and care. She is an optometrist and ocularist by profession and has completed her bachelor's in optometry from Lotus College of Optometry, Mumbai, and has obtained her clinical fellowship in optometry from the Premier Institute, LV Prasad Eye Institute in Hyderabad. Ma'am has continued to work in the glaucoma service department and is trained in ocularist under Dr. Kuldeep Raizada Sir, American Board Certified Ocularist. Ma'am has a rich experience of working with patients with variety of conditions like injuries, retinoblastoma, and birth defects, right from the age of 6 months and up to the age of 80 in all ethnicities. She has also published her case reports in reputed journals of India. Ma'am currently is dedicated in a private practice and is attached to NHSRCC Hospital and Shri Aurobindo Nethralaya, Raipur. So I would like to hand over the time to Dr. Ms. Madhulata ma'am, and she would share her expertise. Thank you.
Madhu, you need to unmute.
Yeah, thank you, Ravi, for the very kind introduction. I'll just share my presentation, and I'll try to keep it short as possible because we're already running late. Some of the images, what you might see, are quite ghastly. So I would just like to talk about anophthalmos. Anophthalmos means loss of an eye, a no eye. I would like to acknowledge my mentors and the institutions I've worked with, and many of the patient images I'm going to share are from these places. Uh, just a small introspection. When you look in the mirror, what do you look for? I'm sure everybody does that the first thing in the morning once they wake up. They would see their face, whether their face is all right, and whether they need to shave or not. How do they need to get dress up, and they will imagine and then get ready. So I'm sure nobody would go out like this, like face half shaven or half makeup done on the face, and they would step out. I don't think anybody would like to step out like this. Suppose you go to a mall or a grocery store and you would see two kinds of people. One having the beautiful eyes and the other one having a disfigured eye. So who would you be comfortable approaching? Or rather, this person who is there behind the counter, whether he will be able to service you, whether he will be given that opportunity to work and service you. So these kind of questions always go behind our mind when a person is behind the counter, and whether or not we should approach them, whether or not they will be able to provide us. So many studies have been done since many decades that how loss of the eye affects the psychology of the person and how the social acceptance matters. So it affects the self-esteem, and in addition to that, it also causes poor cosmesis. So how we can come about to change this attitude in the patient and the society, how we can change that. That's what is the today's topic. So I would like to highlight one more thing. I'm sure you're seeing two pictures here. One is a branded shoe from Nike, and the other is a local shoe which you can purchase for 500 to 800 rupees in your local market. So what is the difference? Why would somebody go for a branded shoe and not for a locally made shoe? One is comfort, the other is quality, and definitely a style statement. Another analogy is, can anybody recognize the gold in the picture? If anybody can. So the beautiful actress Tamanna is wearing Malabar gold, and the lady on the left is wearing something which looks like gold. So a similar thing exists in artificial eyes also. The one on the left is stock eye, or also known as ready-made shell. The one on the right is a custom-made ocular prosthesis or a custom-made artificial eye. So both look very shiny and new in the beginning, but what happens to the stock eye is it would deteriorate and have opacities and discoloration, decomposition. So when it happens to a patient, how will it look? The patient will have a chronic inflammation in the socket, constant discharge, and an ugly looking prosthesis. I'm sure nobody would like to look somebody like this, and the patient is definitely not comfortable looking like this, but he has no option, or so they think. So why would somebody go for a custom-made ocular prosthesis? First of all, I would like to make it clear it's not an optical device. It's not for vision. It's only for a cosmetic enhancement. And it can be fit in any patient who is having a disfigured eye or lost an eye due to injury or cancer or anything. The main advantages is it maintains the socket anatomy because it is made from a biocompatible PMMA material. It is long lasting. Usually in adults, it lasts for about 5 to 8 years. Children would need earlier replacement due to their growing phase. It has good motility in many cases. It replicates the iris color very well, and virtually the patient doesn't have to do anything for maintaining it other than cleaning it occasionally. Patient can wear it overnight, and polishing and modifications are possible in each of the patient. And most importantly, nobody has to wait to grow up to wear this, and it is suitable for all age groups. So I'll just briefly touch upon the procedure. The patient's socket or the eye, which needs the artificial eye, will need to be taken an impression. And once we get the impression, we make a wax model out of it and put it in the patient's eye so that the size and shape are optimally matched. We would match the iris color with the fellow eye and match the scleral shade, add the veins, and polish it, laminate it, and then put it into the patient's eye. The final result might look more or less like this, depending on the case. So a small note on indications. Although this is a seminar on awareness of eye cancer, I would also like to highlight other indications who would require artificial eye. It could be anophthalmos, that is loss of the eye, microphthalmos, a small eye by birth. The other indications could be injury, painful blind eye, or an eye removal after malignancy, anterior staphyloma, retinoblastoma, or a chemical injury, contracted socket. These images might be very ghastly, but it's just for enunciation. Many people have already stressed about this, and I cannot stress any less. The eye grows completely by 5 years of age, and it grows rapidly in the first 1 year of life. So it's very important we pay good attention to the facial growth. The orbit or the eye acts as a stimulus to growth of the face. So if there is any loss at the early stage and the loss is not compensated for by a prosthesis, then definitely the face wouldn't grow normally. And you can see in this picture, the child who had come was already 5.5 years of age, and his face is not grown. So not much can be done for his facial development when he comes this late. So The message is everybody should strive to save the eye and reduce the spread. And in any unfortunate case, if the child has to lose the eye, he doesn't have to look ugly and disfigured and lose his confidence for the rest of his life. So the one on the left picture, that child had lost the eye due to retinoblastoma, and she was fitted with a custom-made artificial eye. The one on the left was born with a microphthalmic eye, and a custom-made artificial eye was fit over the existing microphthalmic eye. A small take-home message that I'm sure we all can work together with general practitioners, teachers, and parents can be sensitized, social workers, and with this workforce, we can save the eye and also create a awareness that this option is available to rehabilitate the patient. Thank you for your patient listening.
Thank you so much, ma'am. I'm sure the one of the reasons why we have Madhulata ma'am with us is because we want to bring up this information to everyone that if you are losing an eye, or if a cancer is causing the loss of an eye, there is a possibility that you can reconstruct the eye and make all the custom changes to the face, so that there is no visual deformity, there is no deformity in the body image. And that is also, it is a very useful thing, because it really demotivates the person, the patient, the children, the adult. And this is really important for all of us to know, because this is the right advice which we can give to people who will say, what if I lose my eyes, what is the next thing? We have a question in the group that if a custom made ocular prosthesis is done, do the patient gets the normal vision? Madhulata ma'am, can you just answer that quickly?
Yes, it is not to restore the vision. It is only for cosmetic rehabilitation. I am deliberately putting the rehabilitation word because it does affect the psychology of the patient, his outward appearance. So it is not for it is not for vision. It's only for cosmesis.
Yes, thank you. So, but that is also very important, because we're talking about the body image, we're talking about confidence, we're talking about many aspects, and it is very essential that with a deformed face, nobody approaches the people for anything. So it is best that we advocate for these patients and we give them the right direction to this. Moving on, we will be going to the most awaited part of the program. That is, we will be listening to Megan. Before that, I would just like to share a bit about Megan. She will be talking a few points about advanced and differential diagnosis. So Megan Weber has launched Know the Glow after her son Benjamin was diagnosed with Coats disease in 2009. Megan is also the advisory board of the Vision Center of Children's Hospital in Los Angeles, California, and co-chair of Bright Eyes, a volunteer organization dedicated to supporting the doctors and patients at Child Life Hospital. Megan has graduated in 1990 from the University of Notre Dame with a BA in psychology and a second concentration in business. Knowing that most parents like herself don't understand the risk associated with the glow or the simple steps to take for the child's eye and health, she knew she had to take action. So together with the help of her friends, she has launched Know the Glow to prevent children from unnecessarily going blind. So with this, So with this, I hand over the time to Megan. Megan is presently right now live from Los Angeles, USA, and she will be sharing to us everything that she has been doing since she has found out that her son has a Coats disease, and he's completely fine now. And what more can we learn from Know the Clue, and how we can help each other, and we can try to learn and grow. This is something that we are looking forward. So I hand over the time to Megan. Um, Thank you.
Can you hear me?
Yes, perfect.
Can you see the screen?
Yes.
First, thank you, everybody. I'm so grateful to all of you for staying a little late. I'll try to be speedy too, as I know you have your day to get on with. But I so appreciate you taking the time to be with us here today. Larry, you're amazing for pulling this all together. Really, you're an inspiration to me here. And I know you are to all of the other panelists tonight who are equally phenomenal. So it's wonderful to be beside you guys tonight, today, sorry, this morning for you. And I'm really excited to share with you a little bit about our story. So even though we're clear over here on the other side of the world, there are so many similarities in so many ways. Just as in India, there are big gaps in our vision care for children 0 to 5. And we really are trying to work together to try and see if we can find better ways to fill those gaps and find children and bring them to care to be treated by students and optometrists and medical professionals, just like all of you. So I'm really grateful for the opportunity to share this story. Not only do I want to tell you about how we came to find our son's disease, but then to try and talk to you about how we did try to change that journey into a new path that now looks for partners all over the world. I know Larry has been sharing some of the photos. We do try to help find other children with cancers and rare eye diseases who are still out there just waiting to be found. One of the things that wasn't really mentioned is, you know, and I'm sure you all know this being med students, but there are no pain sensors in the eye. So, you know, there in many instances, the only indication that there's anything going on within the eye is this crazy glow. So let me introduce you to my son, Benjamin. This has been 10 years ago. He'd probably laugh at this photo now. He was just turning 5 years old at the time. And in most pictures, everything looked fine. This is my family with my other 2 children and my husband. But every once in a while, pictures would show this golden flash. And as was mentioned, it was mostly in night photos. It wasn't in every photo. It was occasionally if there was an evening event, or for us during the holidays or Halloween. It looked almost like a gold coin, and it was just this sort of flash. Ben had a freckle in his left eye. He has a freckle in his left eye. And at first I thought maybe it was just due to the coloring of the eye. And I was even trying to erase it or correct it in Photoshop. My sister, though, we went on a vacation that summer, and when she was with us, every single photo she took of Benjamin showed that glow in his left eye. And she remembered hearing on a TV show some 10 years before that could be an indicator of a tumor in the eye. And so while she was sure that wasn't what it was, she wanted me to go ahead and get it checked out. So remember, this is 10 years ago. I started poking around on the internet back then, and the only thing that came up at the time was retinoblastoma. So of course I started to panic, and I read more, learning that, as you've heard, it's cancer of the eye. It can spread to both eyes. It can be fatal if it passes to the brain and it's not caught in time. So I immediately put Benjamin in the car and went to see my pediatrician and had him look at these crazy photos on the camera, which I really try and always encourage families to bring your photos. Or if you're seeing it in a dim room with a crib or something in the dim lighting, try to be able to replicate that lighting when you take your child in to be seen at the doctor. Anyhow, so he didn't see anything. The pediatrician did the red reflex test, and he, I don't know if he didn't dim the lights long enough or what, but he didn't see anything. But he did refer us on to a pediatric ophthalmologist just to be sure. And when we arrived there and they covered Ben's right eye, his left eye couldn't see that giant letter E all the way across the room. And even though it was the size of a full computer screen, and while he was 5 years old, he was completely verbal. He was not a child that was bumping into walls. He wasn't complaining of any loss of vision. I think one thing that wasn't mentioned earlier is so many of these diseases come along so slowly that the other eye just compensates. The brain starts to shut off any input from the affected eye. And so we were completely shocked to learn that our 5-year-old son wasn't telling us that he couldn't see out of that eye. That shock doubled when we went to the next room, and the scans of Benjamin's eye showed this large white mass in the eye that the doctor believed to be retinoblastoma, cancer of the eye. And this mass, as you've heard, is what was causing the reflection. We were immediately sent to the vision center's pediatric surgeons at Children's Hospital, Los Angeles. And when we walked into the hospital, we found the doctors literally standing there waiting for us. They took us aside. Now here you can see the difference of how much clearer the glow is with a dilated eye. So this is the day that he was diagnosed. We took him in, and as they dilated the eye, they started to tell us that we were looking at one of 3 possible different diagnoses for Ben. The one I'd known about retinoblastoma, but I was anxious to hear that there were some other alternatives. Coates disease and von Hippel-Lindau were mentioned as other potential diagnoses for Ben. Coates is also a lifelong disease that can damage the eye to the point where eye removal is necessary. And von Hippel-Lindau is another form of cancer that typically first presents in the eye, but then leads to tumors in other organs of the body later. It would take 4 days of waiting before we'd get Ben scheduled to go into the operating room to know for sure. But after 2 hours in surgery, when the nurse came out to get us and I saw the smile on her face, I knew we would be okay. Ben's diagnosis is Coates disease. And in Coates disease, the blood vessels are leaking fluid that's collecting inside the eye. The body's not wicking it away quickly enough, and the lipids and fats are remaining and causing the retina to separate. That collected fluid is what is reflecting back into the camera when you flood it with light instead of the healthy red blood vessels in the eye. Tumors, as you've heard, that are growing in the eye can reflect the same way. Fortunately for Ben, we'd caught his Coates disease just in time. He's been a trooper, and while he's had 3 laser eye surgeries, has more surgeries ahead of him, and while he may still one day lose that eye, we get to keep his 10,000 other pieces. And as Larry will attest, it's amazing how quickly you learn not to be greedy. We are so grateful that now we've watched Ben grow, and here he is. Fast forward, he's 16 now, and he still struggles with his lack of vision in his left eye, but he plays sports. He loves lacrosse. He's never let his vision impairment hold him back. But once the clouds parted and we were diagnosed, we could see we were clear of the biggest dangers, but we had so many questions about the glow. Mainly, why didn't we know that this could be dangerous? What if we had waited a few more months and they needed to remove his eye then? What if this had been retinoblastoma or von Hippel-Lindau? What if my lack of awareness had resulted in Benjamin losing both of his eyes or his life? We didn't want another child to lose their sight needlessly, and we didn't want another parent to have to carry that guilt. The more we worked with doctors, the more we began to learn, as you've heard tonight, that this glow is an indicator of some 20 different eye disorders and diseases, many of which are very common and highly treatable, especially if they're caught early. We learned that it's most often parents who find the glow first and bring their child in to be seen, which is why a big part of our campaign focuses not only on educating optometry students, medical personnel, and teachers, but also focuses on trying to educate the general population at large so that we can reach out to the mothers and fathers, and as you've heard, the grandmothers and aunts and uncles that are out there taking photographs of children. We've learned that up to 1 in 80 children will present with a glow at some point before the age of 5. And, you know, because of all of this, my sister and I decided to join with some friends and start this awareness campaign to work on getting this message out. We called the campaign Know the Glow, and we focused on educating people about the dangers of that glow in photographs and the need for early vision screening. We developed a website listing some of the important facts about the glow, how to spot it, what to do if you find it. We created a public service announcement where we told the story through 12 families whose children have lost either one or both eyes to glow-related diseases. And we've partnered with other organizations to work together to share the message and find more at-risk children. In the beginning, we had really hoped to find just one child with retinoblastoma, Coates or von Hippel-Lindau. And as we came to learn more about the global impact of blindness, we widened our scope and tried to build approachable messaging that would inform but not frighten people from all over the globe. Now we hear from families all over the world daily. Last year alone, we heard from families in New Zealand, Israel, Africa, Croatia, the Philippines, and India, sometimes from countries I've never even heard of before. Also early last year, we saw a post online of a parade on World Cancer Awareness Day in India. People in Mumbai were carrying signs that read, "Know the glow," if you can see it in the back. And we're spreading the message here to help save the sight of children in India. We began working with the University of Notre Dame's Bullard-Parseghian Rare and Neglected Disease Center and partnered with students and faculty there to start campus awareness at the university, to educate students, and also international initiatives to proactively start reaching out to build more awareness. We translated materials into Hebrew for organizations in Israel. And then we shifted our focus most recently to India, where through our joint efforts, we were then lucky enough to meet the team at the India Vision Institute. We began talks about how we can build awareness here, both in the medical community and in the general population, to help you approach and find families right here in India. Since then, we've come to know Larry Wagh and Abigail. Through them, we've met the other medical professionals here today, and now we are so happy to have the chance to meet all of you. We're honored to be here today and so grateful for the work that all of you are doing in the field of vision. There is much work to be done. I spent the weekend listening to many speakers at the IBI conference and learned so much about what is happening in your country. I believe there's hope for so many children and families in India. As Dr. Rao, the head of LV Prasad, said at the conference this weekend, if there's one place with the most potential for impact, it is diagnosis. 80% of these conditions are highly treatable or even reversible, but you can't treat them if you can't find them. If there's one thing we've learned, it's that there's no limit to what you can accomplish. Even with one small voice, one rare disease, and 3 little words. And there's no better way to heal than to help make sure that the path for others will be a little straighter and a little shorter for those who follow us. So on World Sight Day, there really is hope in sight. Even in this post-COVID world, our hope is in all of you. Now that you're all so well informed about leukocoria and the different conditions it can indicate, we would really welcome your help, your ideas, your support in sharing the message and building relatable awareness here, demystifying eye care for the general population, sharing the message of awareness and the need for vision screening in a way that will resonate with all of the people in India, helping to find and guide to care those children who don't yet know they need to be found. Thank you.
Thank you so much, Megan. That was a very wonderful representation of what you have started. And it is really important for us. It is really important for us as individuals to know that it really takes a lot to come out there in the world and come out and speak about what you want and what you want to make sure have create an impact in the world. And Megan, you're an inspiration for me because that is what, as a parent, I would like to be, knowing that my daughter is still undergoing treatment for retinoblastoma and there are so many challenges up ahead, but still I want to make sure that a message that goes out to everyone that we need to identify these kind of cancers soon, and any of the eye issues with children especially. And what better way to do it in front of magnitude of nursing, optometry students and faculty, and on this very auspicious day that is World Sight Day. It is the right message that we are getting an opportunity to give out to. I would like to thank each and every one of you for joining in. We are not done yet. I just have a few more things to share with you. So this was about the program that we have arranged for today. It was a very short duration program, but we wish to do more, and for which I would like you all to please share your feedback at the end of the meeting. I will just share the link with you for the feedback. Right now, we're just going to take 1 or 2 questions. There is a question for Dr. Yogita ma'am. The question is about, I'll just get the question to you, ma'am. Yes, what is the role of government of India in regards to testing the preschool children, as most of them are below poverty line? So if you could just...
Yeah, thank you. Thank you for the question. In fact, definitely government of India way back before few years ago, I mean, I would say more than 15, 20 years ago, they realized that there is a need of this particular screening of the children, and most of the children, what we thought, I mean, thought today in the presentation as well, uncorrected refractive error. And due to that, the students were not going to school, they were not pursuing their education. And that was becoming the dependency on the parents, like, the social economical background, especially they're coming from the poverty scenario. So they have started the initiative called Right to Education. And in Hindi, we say Sarva Shikshan Abhiyan. So every district has a one regional office basically. So below from 5 years to 14 years, every child has a right to educate. And in that, whether they need any books or some material of study, or even the fees are being taken care by the government. And even midday meal is also sponsored for the poor children, so they can able to at least come in the afternoon time and have a midday meal also. So education, the food, the psychological support, financial support, and educational material support is being government has been taken care by this particular initiative, the Right to Education. So it's not about the poor, it's about the all over India, irrespective whether you are in Mumbai or you are in a district or any rural area also. So even in Mumbai also, I have recommended many children probably to get into this particular advantage or benefit of this particular, like the government has started this initiative. I hope I have answered the question to the participants.
Yes, yes, ma'am. Himika, ma'am, would you like to add something to this?
Yeah, so the only concern is maybe Yogita can give inputs, or we have other faculty also. Do we have any support from the government to take care of children below 5 years of age when it comes to vision screening? 0 to 5 years.
As I said, I mean, before, yeah, below to 5 years, as of now, as you said also in the presentation, government has really not thought of, because the statistics probably are not showing, it's not very alarming to the government if certain causes
Correct.
can lead to the visual impairment before 5 years. So I
Yeah,
think so we as a professional or NGO or some, we need to take care of that and give the government this report.
yeah, so Megan really,
So maybe they can.
yeah, you're right. So Megan really summed it up well. She said that there are gaps and we need to bridge those gaps. So that is the situation. In 0 to 5 years of age, our government is focusing on malnourishment and other diseases which are life threatening. So the entire focus and budget goes towards that rather than focusing on vision. And it's only at the school level, 5 years and above, we are focusing on vision and right to education. So whenever we try to do anything in the community, we should consciously try to bridge the gap. That is how I look at it. So focusing on, and this is a sincere request even to all others on the group, that already we have a lot of programs and things in place taking care of children above 5 years, and obviously for adults it's all in place. We have cataract initiatives and so on and so forth. What is lacking is the 0 to 5 years. And if you miss looking at the eye at that age group, you miss out on a lot of bad diseases, as many
Yes.
of the people have mentioned. So that's where we need to shift focus, especially because we belong to eye care and being health professionals from that background. We should consciously spread the word, and that's what we are trying to do today. Keep holding you all. I think for Megan, it's almost midnight now. Sorry, Megan. So, but it's important. This is very important. We have other questions also.
Yes, we have a question for ma'am with related to optometry. The posterior pole makes up about 2.1% of retina, while the remaining 97.9% is anterior retina. So if a tumor is present, which is
Anterior retina
yeah,
and not yet invaded the
in the
posterior pole yet, can it be missed, and how do we avoid this situation? Well, that's an interesting question. First thing, you will get a white glow when 2/3 of the eye is full of tumor. So generally, by the time the retinoblastoma or the coats has increased enough to occupy 2/3 of the eye, that's when you'll get the leukocoria. So with the leukocoria, it's very obvious, you can't miss the disease. Coming to the second part of the query, if it is just anteriorly or rather in the periphery, Technically, yes, it is possible to miss some lesions on the sides, on the very edge of the retina, not bang in the center or in the posterior pole. And that's why dilated examination under anesthesia is mandatory. So first the doctor would have a look, dilated examination in the clinic, especially if children are below 5 years of age. It is not adequate to just do a awake examination, and so they are administered short anesthesia. And that's how Megan also very beautifully described that first he was diagnosed in the clinic, there were the photos of those. And then just to be doubly sure, we take them into the anesthesia, and after putting them to sleep under anesthesia, we do a complete evaluation, and there are techniques to do that so that we don't miss out any nook and corner of the eye. I hope that answers
Yes.
it.
Thank you, ma'am. Is there anybody else? We can take one more question before we end the meeting. So if there's anybody else who wants to ask any question, can do so.
And Larry, you might want to again post the form. Everybody can
Yes.
please fill the form.
Yes, please do fill the feedback form. And I also would like to announce to everyone that we are trying to have trying to set up a research with Megan and Know the Glow, and some sort of a way where we can approach and meet the need, where we can identify where are the needs where we need to work on, and how do we establish this gap, to reduce this gap which we have of identifying and diagnosis. So if anybody of you all are interested in the research, please fill the feedback form. We have a special mention there. And definitely you all can coordinate and volunteer for performing some researches, and we can work something out in that direction. With that, I would like to thank each and every one of you. I would like to share the visual description of the form. If you have not, you can take a screenshot of this and fill it later again. But all I request you is to please fill out a feedback form for us, which is going to be really helpful for us to conduct such more events. I would like to honestly thank each and every one of you who have taken up time today and attended the meeting and the webinar today. It was a wonderful, wonderful session. Thank you so much, Megan, for joining us from Los Angeles, USA. And we have a difficulty of time. Yes, we cannot change that, but then we can always try and manage some things in some way. Thank you so much, Dr. Himika ma'am, for being present and for sharing valuable inputs on early diagnosis. We also had Dr. Yogita ma'am, who's such an inspiration. I want to learn so many things from you, and we want to have you again for many of our further events. We have got received many new topics that the students and the faculty also want to learn more. So we can also host few more webinars in the future. I also would like to thank Dr. Madhulata ma'am for giving a perspective of the ocular prosthesis, which is really important in today's world. And it is all available for us in India. We do not have to run to different parts of the world to get them. So I really appreciate each and every one of you for joining. Thank you so much. Please fill the please fill the I'm sorry, yeah, please fill the feedback form for us. It will be a great help for me and for everybody who have taken their time in getting this done. Thank you so much for attending. If there is still any question that you want, you can please ask us. I will give you the references of all the presenters. You can also approach them if you need anything. Thank you so much and have a wonderful day. Happy World Sight Day. Let us join hands and let us reduce blindness. Let us bring sight back into everybody's lives. So this is my humble message to everybody. Thank you very, very much. Thank you so much.
Thank you.
Thank you. Good night, Megan.
Bye. Bye.
Bye, good night. Thank you. Good morning.